Hey everybody, it's Kim. My presentation this week is on hypokalemia and hyperkalemia. Potassium balance is normally maintained by the kidneys and the GI tract. Potassium disorders are common and are caused by changes in potassium uptake, excretion, and transcellular shifts. Hypokalemia refers to serum potassium levels that are less than 3.5, and generally this refers to a loss of total body potassium. Potassium is lost from the extracellular fluid, and therefore potassium is moved through the concentration gradient from the cell to the extracellular fluid, and the intracellular and extracellular potassium ratio is maintained, and this leaves the total body potassium lacking. Hyperkalemia refers to serum potassium levels that are greater than 5.5. Hyperkalemia is generally an increase in extracellular potassium, and decreased excess total body potassium is considered rare. The kidneys are generally able to secrete excess potassium, but injury to the kidney, whether it's acute or chronic, can impair this ability, and that generally is what leads to hyperkalemia. Causes. Common causes of potassium disorders are reduced or increased potassium intake, although that's the least common. Intracellular shifts, cell injury, alkalosis and acidosis, and then medications such as diuretics and vitamins, and some high blood pressure medicines as well. Kidney disorders, and then GI disorders. Hypokalemia is caused by intracellular shifts of potassium to the intracellular fluid with decreased body loss of potassium. This is done through disorders such as reduced potassium intake, alkalosis, GI disorders, excessive nausea and vomiting, and then kidney disorders. Medications such as diuretics, laxatives and enemas, corticosteroids, excess insulin, and intoxication with medications like verapamil and barium are also associated with hypokalemia. Hyperkalemia is caused by excess intake, intracellular shifts of potassium from the intracellular fluid to the extracellular fluid, and that's done through cell injury like hypoxia, severe burns, and severe bodily injury, extensive surgeries, acidosis, insulin deficiency, and again, kidney dysfunction. Medications that can cause hyperkalemia are ACE inhibitors, and then ARBs or angiotensin converting receptor blockers, NSAIDs, potassium sparing diuretics, just to name a few. It's good to note that in cell injury, if kidney functions maintain, excess potassium will be excreted. However, as the cells begin to repair, hypokalemia can result if potassium replacement efforts aren't maintained. So monitoring potassium levels and kidney function are really important after injury and surgery. Supplemental potassium also can lead to hyperkalemia if you're not monitoring that as well. For any treatment, the number one goal should be to correct the potassium deficiency without overdoing it. Overdoing it in either direction can actually cause cardiac or neuromuscular disturbances. Treatment for hypokalemia is potassium replacement through parenteral replacement, oral replacement, or both. It's important to consider the source of the potassium loss and correct that as well. If medications are the cause, stopping or finding an alternative for the medication is necessary. IV replacement should be reserved for severe hypokalemia, generally less than 2.5, as this is the form of treatment that can quickly cause hyperkalemia, as well as just pain and phlebitis to the IV site. Oral replacement can provide correction when the need's not severe, but a combination of IV and oral is a possibility as well. Treatment for hyperkalemia is focused on decreasing the serum potassium level while treating the underlying cause. Urgent treatment would include IV calcium if you notice EKG changes are present. hyperkalemia can be life-threatening. IV calcium helps to stabilize the cardiac muscle cell membranes. Insulin administration and albuterol administration helps to shift potassium into the cells, but does not affect the total body potassium. So for hypokalemia that's not severe, Kayexalate can be given, and that binds to potassium and eliminates it through the GI tract. For my case presentation, 32-year-old female patient presents with weakness to bilateral upper and bilateral lower extremities. This has been progressing over the last 2 weeks and now has become severe in the last few days. She has a history of hypertension, is currently on lisinopril 20 milligrams a day and hydrochlorothiazide 25 milligrams a day. She also has a history of gastric sleeve procedure about a year ago and reports occasional episodes of diarrhea, with the last episode a week prior to and lasting for about 3 days. Muscle weakness is present in all extremities. Her deep tendon reflexes are slightly slow. CBC is normal, but the CMP does show a serum potassium level of 2.6, a slightly elevated BUN and creatinine and magnesium, and all other values are shown normal. She denies any chest pain or palpitations, but her EKG does show broadened T waves. So for her, this diagnosis would be hypokalemia, which is associated with GI dysfunction, secondary to gastric sleeve, dehydration due to diuretic use, and potassium losses due to the decreased oral intake and diarrhea. For testing, we did a CBC, CMP, and an EKG, as well as general assessment. For treatment, initial treatment would consist of 60 milliequivalents of PO potassium to be taken every 12 hours for 2 doses, with the first dose now, and then a follow-up CMP to be performed in 24 hours. Additional dosing could be provided if the serum potassium levels remain less than 3.5. A maintenance dose of 20 milliequivalents PO daily would be prescribed, with follow-up labs to be done weekly until the serum potassium level remains within normal limits for 2 readings. Follow-up EKG in 24 hours to check for normal T waves, and then discontinue hydrochlorothiazide and begin spironolactone as a replacement, as that's a potassium-sparing diuretic. Also, a dietary consult would be necessary and immediate for dietary management, with focus on gastric sleeve diet with an adequate amount of potassium and hydration efforts, and foods that would minimize GI upset. And then last but not least, Imodium PRN for episodes of diarrhea. Thank you. If you have any questions, please let me know.